Okay?
Turn the face away?
So, yeah, so again, we don't want the legs and the lap over the table image receptor. We want to turn them away to protect their eyes, their
Thyroid.
thyroid, and also their gonads. It's going to be tabletop. We don't want them like this where they're getting scattered radiation striking them in the throat and the eyes. So we have them turn away. Okay. Oh, where did this come from? Okay, so it's like so. So is this a good way to do this?
No.
Not a good way, okay? So now everything, all the radiation that's hitting the table is going to come back and hit his throat, hit his eyes. Right? So we don't want this, right? We don't want this. So you want to include both joints. So radiographic criteria is the epicondyles are going to be parallel with the image receptor. So it's not only good that you're getting them palms up, but you want to feel for the epicondyles to make sure that they are parallel with the image receptor. Remember those two bony projections on your elbow? You're feeling for those. Okay? Palm up. Collimate tightly on both, all four sides to include the elbow joint as well as the wrist joint. In a true AP, the radial head is going to be slightly superimposed with the ulna as well as a slight superimposition of
Tuberosity.
radial tuberosity. Okay? Whereas the entire part of the shaft is not going to be superimposed. All right? Can you guys tell the age or give some kind of age looking at this picture?
Yeah.
Again, right, because we see the
Growth
growth
plates.
plates, right? So this is a youngish type of patient. You can also see a growth plate here in one of the epicondyles. See that? That's not a fracture. That's an epicondyle.
So in an adult, those lines would be gone?
You won't see those. You won't see them. They'll be fused together. So you won't see those at all.
It's pretty bendy, right?
Hmm? Pretty
It's
bendy?
a little more curved than other ulna and radius.
Well, yeah, the bone themselves are not completely straight. There is going to be a slight bowing to them. Yes. All right. Are we good here, guys? So the next one here is going to be
Lateral.
a lateral. A lateral medial projection. Okay. It's going to be tabletop. Why are we doing tabletop, by the way? Because we did tabletop with the hands, and we're also going to do tabletop. We're not using a buggy. Tabletop for the forearm.
Less than 10 centimeters.
Because why?
Less than 10.
Less than 10 centimeters, right? Less than 10 centimeters. So we don't need a grid. We don't need a buggy. We just do tabletop. Okay. Now for the lateral. Key components here. Arm has to bend at 90 degrees, thumb up. Pinky side down, thumb up. Elbow bent at 90 degrees. It has to be 90 degrees for a true lateral. The other key component here is we want the shoulder rested at the level of the image receptor. Because if my shoulder is higher than my elbow, what is it going to put my elbow in? It's going to be slightly oblique, right? So we want it to be at the same level. Okay, shoulder higher is going to be slightly oblique. So we're trying to get the elbow in a true lateral position. Okay, so hand in a true lateral, shoulder is down, elbow flexed at 90 degrees. You want to include both joints. Wrist joint, elbow joint. Okay, and collimate as close as you can to the soft tissue. Okay, dogs. Now, when you guys were taking x-rays of the hands, did our students talk about the shadows?
Yes.
Okay, the shadows, okay. The shadow is your indicator of whether or not you've got the anatomy within the field of view or not. So when you're collimating, look at the shadows. Okay. All right. Forgot to mention on the last image, where's the central ray directed?
Mid-shaft.
Mid-shaft.
Mid-shaft. So just get the arm in the middle of your central ray. It's mid-shaft. That's pretty easy, right? All right. Elbow flex at 90 degrees. Distal radius and ulna are going to be superimposed, whereas the epicondyles are also superimposed. Okay, true lateral. True lateral. Easy stuff, right? Extremities are easy.
If someone is very tall,
Uh-huh.
we can adjust the SID because the first part has to be the level of the.
Have them kneel down on the ground. Give them a chair. You can either give them a chair, or if they're really tall, like you said, we're going to have them put a pillow on the ground or some kind of folded blanket and have them kneel.
So most of the time, the patient's not in a very comfortable position, huh?
Most of the time, are
Yeah.
they not in a comfortable
Yeah.
position? Yeah, because we haven't talked about trauma yet. What we're talking about here is just strictly textbook type of procedures. So we're giving you the foundation. When you receive a trauma patient, depending on their condition, now you're going to have to modify how to get those projections and views. So we're giving you the basis, we're giving you the foundation, and now you need to modify from that depending on the condition of the patient. So we haven't even talked about trauma yet. It changed, the entire ball game has changed. Okay? Because as we say here as technologists, there's a science and there's an art to it. The art comes in knowing how to use your critical thinking to obtain those views and projections. All right. AP projection of the elbow. Same thing as the AP projection of the forearm. We're just collimating to the elbow. It's the same criteria. Palm up, arm extended, shoulder at the level of the image receptor. Okay, that's it. What are we feeling for here again to make sure that the patient's in a true AP? We're feeling for the epicondyles, okay? Not so much that the palm is up, we still need to feel for the epicondyles to make sure that they are parallel with the image receptor. Collimate tightly to an area of about 4x4 or 5x5. These are just some general numbers that I'm throwing at you, but you don't have to have, you don't need to include the entire forearm, you don't need to include the entire humerus. We're focusing on the elbow. So about 4x4 or 5x5, using a small image receptor. Okay, I didn't mention this before, but where should you place your marker?
Lateral.
What's the lateral? The radial side or thumb side, right? Okay. Again, and the question came up yesterday: is it always going to be that way? No, but we're trying to get you guys consistent here in class and in the lab. There might be a variation by the time you start your clinical practice. But the general rule of thumb literally is marker on the thumb side. Okay? All right. Again, arm extended, palm up, feeling for the epicondyles. Armpit at the level of the image receptor. Have them turn away. Eyes, throat, and lap. Okay? Are we also shielding our patient? Yes, we are shielding our patient, okay? And so what are we telling our patients to do every time we're taking these x-rays? Just hold still. We don't have to hold the breath yet. Okay? Just hold still, don't move, and keep your eye on them. That's why we have windows, right? Because when you step out of the room, again, the moment that you step out, they're curious to see what you're doing, which is fine, but make sure that they don't move during the procedure. Okay, keep an eye on them. Okay, so epicondyles are going to be in true profile. The radial head, neck, and tuberosity is going to be slightly superimposed. Now the neck may not be superimposed, but the radial head and the tuberosity surely will be superimposed. Okay, those are your two key items. The neck may or may not be, but it's the radial head and the tuberosity that we are looking at for a true AP elbow. All right? What kind of KV are we using? Because we used about, what, 40 to 45 to 50 for fingers.
About
in our
55.
wrist. What are we using for the forearm?
55, 60.
Okay, so about 50, 55. What about the elbow? About 55, right? So what are we adjusting here? Are we adjusting our KV or our mass?
Mass.
Okay, you can adjust either one, but the practical practice
Mass, right?
is we're changing KV, because
really?
KV is based on body part thickness. Okay, that's a general practice. Again, there's going to be variations. When you guys go out in the field, you will have technologists telling you how they adjust their technical factors for the different body parts. Okay, but generally it's the thicker the body part, we increase our KV. We may increase the mass, very small increments. But again, this is something that you guys will get accustomed to when working with the different technologies at the hospitals. All right. AP projection, okay? AP projection, when you have someone who's not able to fully extend their arm for you. Okay? Because if you have elbow injury, are you going to be able to do this? Probably not, and they'll be walking or being wheeled into your department like this. Right? So, when you have someone walking in with partial flexion, it's a slight bend. Okay? To acquire the AP projections, you have to do two. One will give you a true AP of the proximal forearm, and the other will give you a true AP of the distal humerus. You guys follow? So one will be done like this, okay, where your forearm is resting on the imaging plate. And the other one will be your humerus sitting on the imaging plate. So one is forearm resting on the plate, whereas this one here, the humerus is sitting on the imaging plate. Yes?
So these are, you have to take both views. This is more what you're looking to shoot based off of the.
Yeah, because again, we can't get full extension,
Right.
okay? When you get full extension, it gives you the entire elbow in true profile. So now what happens here with partial flexion,
So we're shooting both together.
you're shooting, you're shooting both together. Yes. Shooting them separate? You need two projections to,
Yeah.
you need two projections to equal one
That's what I
AP.
mean. Okay.
Yeah, you need
that's
two
what I mean.
projections to equal one AP. All right, so again, one of the proximal forearm and the other one of the distal humerus, okay? When you're taking these shots, again, what are the bony landmarks that we're feeling for to make sure that the patient is a true AP?
Epicondyles.
The epicondyles. Okay, very good. Okay? So, your central ray is going to be perpendicular. Okay? It's only the body part that moves. So the central ray is the one that's perpendicular. It's only the body parts that move. Central ray is still perpendicular. Where's the central ray directed, by the way?
The mid elbow.
Mid elbow joint, right? Mid elbow joint. So, so here again, we know we're in the true AP because on this particular shot, partial superimposition of the heads and the radial tuberosity. This one is slightly externally rotated because these are free from superimposition, but again, this is acceptable. True AP is slight imposition here, slight superimposition here. All right? So one of the proximal forearm and the other one of the distal humerus. Okay? Any questions? Now these are two different patients, by the way, but you know, this is what shows the different shots. You guys see anything wrong with this image here? Okay, well this is the fossa, right? The olecranon fossa. What should be sitting in there?
The olecranon
The
process.
olecranon process. Do you see the olecranon process sitting in the fossa?
So is it dislocated?
This is a dislocation. Yeah, so that's popped out. Yeah.
Not to the right.
Huh?
Towards this way?
It's down towards the bottom.
You can kind of see it in that one too.
You can kind of see it here.
how it
but
doesn't sit- it
yeah,
doesn't sit
again, I don't know
inside
if
of
it's the sa- I'm assuming it's the same patient. I don't know if it's the same one. But yeah, you can kind of see it sitting there off to the edge.
Yeah.
Which may be slightly what do you call it?
Dis-
Slightly
Dislocated.
dislocated, but here you can really tell that it is.
Is it a young patient because of the?
Because of these growth plates right
Yeah.
here? Yeah. All right. Are we good here?
Mhm.
So if it's partial flexion,
Get the-
how many views?
Two.
Two views, okay? One of the
Distal.
distal humerus and the other of the
Proximal
proximal forearm. So one with the forearm sitting on the image receptor,
And one with the
and the
humerus.
other humerus sitting on the image receptor. What about your angulation?
It's perpendicular.
It's going to be perpendicular at the elbow joint, right? That doesn't change. All right, you guys, are we good on this?
Mhm.
Okay, because now there's going to be a variance. This is an acute flexion. This is somebody coming in with their arm totally bent. With their arm totally bent. Now, again, we need two projections or views to equal 1 AP. Condition, completely bent, acute flexion. The humerus stays flat on the image receptor for both projections.
And the projection gets angled, right?
Okay. So, first one here, we need an image of the distal humerus here. So the central ray is going to be perpendicular to the humerus. Perpendicular to the humerus, and you are shooting between the epicondyles. The second one now is going to be perpendicular to the forearm. So how much angle you use depends on how acute the flexion is. You guys understand what I'm saying? It depends on how acute the flexion is, but the second image that you take has to be perpendicular to the forearm. The central ray for this is going to be 2 inches above the olecranon process. 2 inches above the olecranon process. Okay? So one is perpendicular to the humerus, the other one is perpendicular to what?
The forearm.
The forearm.
So the angle will be different just depending on how.
Depending on the flexion, okay? But the key here is, again, it's perpendicular to the forearm, okay? So don't be looking at the angles.
And
just match the perpendicularity to
Both
the
are 2 inches above the olecranon process.
This,
right?
no, this is between the epicondyles.
Oh, okay.
For the humerus. For the forearm, it's going to be 2 inches above
Okay.
the olecranon. All right, any questions? So we have partial flexion and we have acute flexion elbow. Both require 2 views to equal 1 AP.
Is that still considered an AP even though it's going in the posterior side?
This right here? Yeah, because
Yeah.
we're looking at this. We're not looking at this. This is going to be distorted. With this angulation, the humerus is going to be distorted, but it puts this, the forearm in a true AP. And the same thing here. This puts the humerus in true AP, but this is going to be foreshortened. All right. Okay, any questions here? All right, let's keep on going. Okay, now we have here the medial oblique or internal oblique elbow. Okay, arm fully extended. What's your other main criteria?
Shoulder at the
Shoulder at the level of the image receptor. Okay, now what we're going to do here is we're going to do palm down. We're going to pronate our hand. All right? Now, simply pronating your hand is not going to isolate the elbow being in 45 degrees. So simply pronating your hand, I can pronate my hand and my elbow is still flat. Some of us are double jointed. So I can pronate my hand without my epicondyles going in 45 degrees. So pronate my hand, and then what are we feeling for? Epicondyles, and place them at
45 degrees.
45 degrees. Okay? And a good way to also do this is looking at the surface of the elbow and putting the surface of the elbow at 45 degrees. The surface of the elbow at 45 degrees.
So you can
Okay.
start by turning the elbow first and then the hand, if you want
Just
to.
have them pronate it and then adjust the elbow as necessary. Okay? And I don't care what order you do it, as long as you get this in 45 degrees.
Mm.
Okay? All right, guys, any questions? Central ray at mid-elbow joint. Now, before we look at the radiograph, because the hand is pronated, what do you think is going to happen to the radius and ulna?
We're going to cross each
We're
other.
gonna what? We're gonna cross. Okay, so we're gonna cross. All right. So here we have the radius and ulna crossing. This projection, this position, the medial oblique, is good for evaluating the coronoid process. The coronoid process of the ulna. This is good for evaluating the coronoid process of the ulna. Okay? This is the coronoid process. You guys see anything here? There's a fracture right there of the coronoid process. So this is good for evaluating the coronoid process. The medial epicondyle and the trochlea, the medial condyle and the trochlea are going to be elongated. The medial epicondyle and the trochlea are going to be elongated, and the olecranon process will be seen inside the olecranon fossa. The trochlear notch, what's another name for the trochlear notch?
Semilunar.
Semilunar notch is going to be partially open. Okay, any questions here? All right, here is your lateral oblique or external oblique. Again, arm fully extended. Arm fully extended, shoulder down. This is one of the harder ones to do. So what we do in this particular case is we put our patients in a chair, and so they're not going to be sitting completely upright on a chair. In fact, what they're going to be doing is when they sit down, they're going to scoot the chair forward, lean back, and drive like a cholo. You got to lean back. Yeah, you got to lean back, and you've got to push the chair forward. Now, what kind of chair are we going to use? Are we going to use the wheelchair?
No.
No. Okay, because the chair is going to slide down from underneath them, okay? So you got to keep close watch when you're doing this type of position. Seat's going to be forward, shoulder back, okay? Pinky up, thumb down. But again, this is not enough. What are we feeling for?
Epicondyle.
The epicondyles. And we're putting our epicondyles in what?
45 degree.
45 degree obliquity. Okay? We'll practice this in class. Okay? Shoulder down, arm extended, rotated laterally at 45 degrees. Okay? Epicondyles 45, center at the elbow joint. Now, how do you think our x-ray is going to look? What's going to happen to the radial head and the tuberosity?
They're going to be separated.
They're going to be what? They're going to be separated, right? Let's see. Ta-da! They're going to be separated. There is no superimposition. Okay? So the radial head, the neck, and the tuberosity are going to be free from superimposition. The lateral epicondyles are going to be elongated, as well as the capitulum. Okay? Remember, the medial, we're looking at the trochlear side. In the lateral, we're looking at the capitulum side. Okay? So the capitulum and the lateral epicondyles are going to be free from going to be elongated. Okay? Any questions? Now the last one here is the same as the lateral forearm. Bless you. Lateral medial projection. Elbow. Again, this is key. Elbow has to be bent at 90 degrees. Now this bending of 90 degrees, is this going to apply to all patients? Okay, again, it depends on their condition and what they can do for you. You may not be able to do this 90 degrees, but you get it as close to 90 degrees as possible. Okay? Shoulder at the level of the image receptor. Okay? The lateral is good for visualizing what? Two things. The lateral process and true profile, and we're also looking at what? Concentric arches. Okay, we're looking at the concentric arches. All right, so the radial head is superimposed by the coronoid. The lacrimal process is in true profile, and we're also looking at the concentric arches. The epicondyles are going to be superimposed, right, one on top of the other. All right, questions? All right, let's do the humerus. We're moving up. Humerus. The humerus is the upper arm. We need to include both joints, right? So we're looking at the
Shoulder joint.
shoulder joint all the way down to the
Elbow.
elbow joint. 2 views is what we need. 2 views. Okay? Now you can do this either standing up or you can do it on the table. Again, you need to evaluate your patient and determine what they can do for you. For the first projection, it is an AP projection of the humerus, palm up. But again, not simply palm up. What are we feeling for here?
Epicondyle.
Even for the humerus, we are feeling for the epicondyles, making sure that they are parallel with the image receptor. Parallel with the image receptor, okay? So palm up, center at the middle of what?
Shaft.
The shaft or the humerus. And you're going to open up your collimator to include both the shoulder and the elbow joint. Okay? Shielding is necessary. Yes, do we want to shield our patient? Okay. Now, because we are including the shoulder here, is there any breathing requirement that's involved?
Yes.
Yes. Now what are we going to tell our patient to do? Not only hold still, but
Hold your breath.
hold your breath. And then keep your eye on the patient to make sure that they're holding their breath. Okay? We're going to tell them to hold their breath.
Dude, you gotta.
What is happening?
There's something
here?
going on.
This room is haunted. What's going on? Okay. So palm up, epicondyles are parallel to the image receptor, centered in the mid-humerus, and you're going to have them hold their breath. All right? Now, when the patient is in a true AP, you will definitely see the greater tubercle, okay? And then you're going to see the lesser tubercle right here. And what's in between? Bicipital groove. Okay?
Bicipital.
All right, so greater tubercle is going to be in profile. Remember, the greater tubercle is lateral and more superior than the lesser. Okay, it's going to be lateral and more superior. So the greater tubercle is going to be in profile, which means it's going to be demonstrated. Okay, so the greater tubercle is demonstrated. The humerus and the glenoid fossa are going to be slightly overlapping. So the head of the humerus with the glenoid fossa of the scapula are going to be slightly superimposed. Okay? And then the epicondyles, because you put them parallel with the image receptor, should also be in profile. Now, why is there a change of density from shoulder to elbow?
It's thicker up top.
Because it's thicker on the top. So this is film. So what do you think is going to happen with computerized radiography?
It's gonna look
It's going to
even.
be even from shoulder to elbow. You guys are so lucky. I've said that, right?
Mhm.
Many times.
You gotta get some of
I just remember you saying haters.
that. Just a little bit. Just a little bit.